So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Radiation oncology is multi-disciplinary.
Sure. So most of
I feel like I'm on a ride.
with radiation oncology, and with drugs, systemic therapies, one type or another, and that would be medical oncologist. And then, there's more to the cancer team than just the MDs. There's the cancer nurse, there's nurse navigators, dietitians, social work, dedicated oncologic focused diagnostic radiologists, pathologists, and these groups come together in tumor board. And at a multi-specialty group practice, like where I'm very fortunate to practice, we also interact constantly throughout the day. And depending on the stage and type of cancer, it can involve the surgical oncologist, radiation oncologist, medical oncologist, or any permutation therein.
So what is the role of a radiation oncologist, like at its core?
So it's a very fair question. Some of my best friends still think I'm a diagnostic radiologist, which is a really different field. So, as a radiation oncologist, we treat cancer with radiation. There's actually an increasingly large number of non-malignant diseases we treat with radiation these days as well. But that's what the radiation oncologist does. For cancers that are radiosensitive at the stage where we're called on to treat, that's the service we provide.
Perfect. So we know radiation therapy is the service you provide. What exactly is radiation therapy?
Yeah. Great question. So, radiation is a word that evokes a lot of understandable, apprehension. But in the context of medical radiation and the treatment of cancer, we're using high energy X-ray beams in the most common context of giving it. That are tightly focused on the tumors, and radiation causes some unique types of damage to cancer cells that actually cancer cells really can't repair. Normal tissues actually can repair that type of damage, and that's how we're sort of able to harness this very natural force of radiation to kill cancer cells. Radiation's a local therapy, so akin to surgery, the radiation beam only has effect and side effect where we aim it, and that's in contrast to what the medical oncologists give, which are drug therapies that sort of work the whole body over.
Yeah, and I think it's an important distinction. And I think as we kind of move forward in this conversation, we're going to talk about why, in a lot of cases, either as a mono or singular therapy, radiation is great, but also how it works in combination with other therapies for even greater responses in some cases. Just for a quick show of hands and no pressure, nobody has to raise their hand if they don't want to, regardless of the answer, but how many folks in the room have had radiation as part of their therapy? Yeah, so a decent amount. Yeah, which is great. And I really encourage you guys, as we're having this conversation, to comment on your experience or any questions you have about how maybe decisions were made, because I think the decision-making process of when and how to bring radiation is I know something we hear through the helpline and folks that are calling us from around the world all the time. Okay. I mentioned earlier, it's not your grandfather's or your great-grandfather's radiation. So I've already sort of set the stage for radiation being different now. Can you talk a little bit about how it's different and the different types of radiation therapy?
Sure. So in the context of lung cancer, we're almost exclusively talking about external beam radiation, which is where we're aiming radiation beams from the outside in, focused on the tumor, lymph nodes, whatever structure we're trying to treat. And there's been a lot of advances over the decades. Radiation was discovered in 1898, and within 1 year it was being used to treat cancer. Of course, they had no idea how it was working or how to target it. But over the decades of the 20th century and well into the 21st, we've gotten very good at designing our radiation beams to be very focused on the tumor. One technology is called intensity modulated radiation therapy. Maybe the next generation of that is what we call rapid arc or volumetric modulated arc therapy. But these are ways of using numerous beams of radiation that are focused on the tumor, and that provides, in many cases, very negligible dose to the normal surrounding tissues and high doses to the tumor, and that's important. We've also gotten a lot better at targeting the tumor, and so the main technology around that is called image-guided radiation therapy, or IGRT, and that lets us be very accurate and precise in the delivery, and that's especially important when we're giving high doses of radiation therapy. And then in the direction of the high doses of radiation therapy, there's a technique that I have a particular passion for called stereotactic body radiation therapy, or SBRT. Some places call it SABR, but these are synonyms. And that involves delivering really quite robust doses of radiation with literally sub-millimeter accuracy. And in the context of the lung, that requires us monitoring and managing motion because these tumors move. And so that's delivering entire courses of radiation in typically 1 to 5 treatments. So these are a lot of the really exciting developments. There's internal radiation, less of a role with lung cancer. That's called brachytherapy. I think that's a pretty good overview.
Yeah, I think it's great. So just to hopefully prevent any confusion, because I feel like that was sort of a lot. So in some instances, I guess that sort of like in a nutshell, back in the day, whenever that day was, radiation therapy was given, a beam was set as close to the tumor as possible, and this is regardless of cancer type, right? But unfortunately, a lot of healthy tissue was damaged in that process because there wasn't an ability to really streamline and target and pinpoint where the radiation beams were going. And so whether you're talking about IMRT or, I mean, a lot of these things, it's similar, it's a different type, but effectively the same outcomes, the same sort of idea.
Yeah, I mean, the targeting has just gotten so much better. I mean, for one, in the earlier times, the beam design was done on just a front to back x-ray. And so basically they had to put these very large margins to make sure you would cover the tumor, and that really limited the dose you can give safely, a lot of toxicity, not really the best outcomes. These days we use all the imaging modalities that exist in the sphere of medicine. We do what's called CT simulation, so we're using 3-dimensional imaging to target. At our center we use what's called 4-dimensional CT quite often, and the 4th dimension here is time, so we're actually monitoring the tumor moving, so we're not just putting these big margins on, we're tracking the tumor in real time. Sometimes we'll actually have implanted markers within that tumor that we can really lock onto. And then we're incorporating the other diagnostic modalities of MRI in some cases, especially when we're treating along the central nervous system, which is sometimes unfortunately relevant in lung cancer, as well as PET, and really everything in between. Everything we can get our hands on, we're going to use.
Yeah, the technology of using this sort of in real-time imagery to guide, especially because I don't know if it's something prior to me 17 years or so ago entering the space, I didn't give a whole lot of thought to how they might radiate a lung that is breathing and moving, and you set this beam and then somebody takes a breath because you need to breathe, and then all of a sudden, like how, right? And so I think it's fascinating to me, and I can only imagine how much better this is going to get as we sort of continue through this process.
Definitely.
So kicking back a little bit, sort of along these same lines, what can someone expect if they are told radiation therapy is like the best next step or first step or whatever step it is moving forward from a, can you explain a little bit about the mapping and what that process from the patient perspective might look like?
Sure. So, you know, unlike ordering like an MRI or a CT, this really involves a physician consultation. And sometimes those consultations are sort of like pre-screened in the context of tumor board. Sometimes I'm treating patients from a great distance. I'm meeting for the first time and reviewing outside records, but it begins with a consultation. It really, we really need to make sure that the individual we're meeting with is really a good candidate for radiation, that in the multidisciplinary management, radiation really is a sensible tool. And sometimes the answer is no, but typically by the time they make it to me, the answer is yes. Then we have to talk through, side effects, and that's going to depend on the volume and sort of where we're treating. But then if we decide that we're going to go ahead, we start with what's called a CT simulation, or the 4-dimensional CT. So the patient's going to come in. We're going to get the patient in the appropriate and reasonably comfortable position, and we have some custom devices and cushions to ensure that. We'll do the scan of the area. We typically make skin marks, which are like tattoos. We're actually rolling out a tattoo-less program at our center, so that's something that we're really excited about. So that's not always going to be part of it going forward. And then from there, the patient part is done. And then from there, we import the treatment planning images into our treatment planning computer. The medical physics staff, and these are amazing people. Like, we work with 3 PhD medical physicists, and the patients never meet these people, but we're really fortunate to have really the best in the business. And they collaborate with the physician in designing the radiation beam, in making sure that the radiation beam that's being designed in the computer is deliverable in real life. That's what's called the quality assurance step, where we deliver the radiation beam to what's called a phantom. The phantom is actually a mannequin with radiation detectors in it to verify that what we designed in the computer is deliverable in real life, and only then do we call in the patient to begin the treatment.
So that's amazing. I mean, you think about all of the sort of triple checking that happens before this type of therapy actually goes to the person diagnosed, which is fantastic. So we're talking right now sort of about treating, I'm assuming from a mapping out and what this process looks like, lung lesions. For brain lesions, it's a little bit different. And I know that's not on here, but I know you know what I'm talking about.
Totally, yeah.
So, but I want to talk about how that is a little different, because I know a lot of folks have had brain radiation and the mapping out and the mask and all that stuff. Mm-hmm. Can you kind of walk us through what that is? Yeah.
So when we're treating the lung, there's no way to like rigidly immobilize the lung because you're breathing, you're swallowing. It's human. When we're treating the head, though, especially when we're giving what's called stereotactic radiosurgery, which is really the approach I favor with brain metastases, we really need sub-millimeter accuracy, and it turns out you actually can immobilize the head. In prior eras, that involved screwing a frame onto the head using a technology called gamma knife. We, like most places, don't do that anymore. We actually make this mask. It's made of what's called thermoplastic material. It starts as this like plastic mesh that's flat. When you heat it up, it becomes stretchable and malleable. We mold it to the patient's head. As it cools, it hardens, and that becomes a rigid mold to hold a patient's head in place. Comfort is acceptable, better than screws in the head. And then we do the same CT. MRI is really what you need to see the brain, so we're going to be fusing in the MRI. That's essential. Turns out PET's not that useful in the brain, but it's usually a CT and MRI fusion. And then from there, the steps are essentially the same. And the most high-functioning stereotactic radiosurgery programs do involve collaboration with neurosurgeons. So that's going to involve a different type of surgeon. But a lot of the anatomic considerations that go into stereotactic radiosurgery are very similar to those that go into proper brain surgery. So that's why they're involved.
Yeah, thanks for that. And I know we're going to jump in a little bit later into a little bit more detail from an early stage, late stage, and what that might look like from a radiation perspective. But I appreciate you walking us through that. So how is it determined? Because I know in groups like this and other program areas that GO2 and others have, people diagnosed are talking to one another, right? And it's like, well, I had this type of treatment, or I had that type of treatment. So a lot of times people are like, well, logically you might think, well, I have this biomarker or I don't, or I'm either on targeted therapy or IO or in chemo or something. But you find the similarities, but then something's different, right? Like, how do you determine what type of radiation might be right for a patient?
Yeah, I mean, in broad strokes, it really depends on the stage of the disease. That's what really helped us kind of calibrate, the best approach for the given patient. And also with radiation, again, it's a local therapy, so proximity to critical normal structures like tumors that are sort of plastered against the heart might need a more thoughtful approach than ones that are sort of sitting out in a field of normal lung. So the anatomic location really matters as well. Volume of disease, stage of disease, nodal involvement.
So there's a lot of thought that goes into it, in other words. I see a lot of nodding heads. So I want to jump into talking through radiation treatment by stage. And how, yeah, oh, sorry. Oh, goodness, I'm so sorry I didn't see. Yeah, no, just, we just need to grab you to grab a mic. No, you just start yelling at me. Just start yelling at me if you have a question.
Oh, okay. It's on. Hello?
There it is.
Okay. If you have lung cancer, but a tumor is found somewhere else in your body, but not in your brain, is this what you do? Is that something you can also maybe radiate? Is that what we're talking about here?
Absolutely, yeah.
Okay.
So actually, one of the most exciting, parts of being a radiation oncologist in this era and treating lung cancer is the real value of treating what are called oligometastasis. So that's O-L-I-G-O, like oligarchy, like few. And so in patients who have like 1 to 3, even up to 1 to 5 tumors that are elsewhere in the body, that's quite amenable to radiation, and that has some very promising outcomes. I'm happy to expand on that now. We could sort of go into it later.
Yeah, I mean, I think, so a lot of folks who are old-timers here, not old-timers in life, but old-timers here, are very, Sally, nobody asked you how old you were today, are very familiar with talking about oligometastatic and oligoprogressive disease. And I think maybe we want to get into it. Well, I mean, I guess we could get into it now. So you guys have heard me say in the past, you're on XYZ systemic therapy. And historically thinking, and I'm just going to simplify this really quick so that he can jump into when and how he best determines. But your systemic treatment is effectively working on 80-90% of your cancer. But you've got these couple little bugaboo spots who are just not liking whatever the systemic treatment is. That's when this guy comes in and does his magic, right? And can hopefully treat those spots so you can stay on your systemic therapy, because historically you'd just come off therapy and you'd switch to something else, right? Because it was considered, nope, your cancer's no longer responding and we have to change your treatment. Am I
Yeah,
close?
that's very well stated. It's sort of the traditional way of thinking about metastatic disease is that if it's moved from the site of origin to somewhere else, that's stage 4. Stage 4 is a systemic disease, should only be addressed with drug therapies like traditional chemotherapies. And you're absolutely right. Let's say there were 10 spots, 9 of them responded, 1 of them didn't. That was considered a non-responder, and then you'd sort of set that drug program aside, never to return to it. That card's been played, and if there were other options, that was good news. But especially if you look back 10, 20 years, there might have only been 3, 4 options, and once you got to the 4th one, that was sort of it. In the current framework, there is this concept of oligoprogression. So again, the same patient, 10 spots, 9 of them seem well controlled with the drug program, and of course these days we're looking at immuno-oncology, we're looking at targeted therapies, and in some cases chemotherapies. But if only one spot is a bad actor, only one spot is growing, presumably there was just one clone of cells that was able to get some resistance. And drug resistance does not predict radiation resistance. We zap it with radiation, get that spot under control, and the medical oncologist and the patient continue on that same line of therapy, and that can be repeated multiple times. I will say, though, that what if all 10 spots are growing? Then you can really say at that point you really do need to switch things up. And usually we say between 1 to 3 spots, at most 1 to 5 spots, is sort of where we draw the line between oligoprogression and macro progression.
Yeah. And I think it makes sense, and you guys have heard me say over and over and over again, like the goal here, particularly with late stage, and we're jumping kind of all over the place in this agenda right now, but is to stay on therapy as long as you can, right? Because we know there might be a second or third line, but we're just waiting for the next best thing. And You've also all heard me talk how exciting the next best things are that are
absolutely.
kind of coming down the pipeline. I'm not ignoring you, I promise.
Yes, you are. No, just a quick question. I'm just curious, how long has this radiation been around?
Sure. So I mean, as I said, radiation's been used to treat cancer for more than 100 years. But like what we'd consider like modern, like stereotactic body radiation therapy, the SBRT, it's been around in its early stages for 20 years. But I'd say it's come to its full maturity in the last 10 to 15 years. Yeah.
I have a little
Yeah.
mini cyberknife model back there in the storage room somewhere from back in the day. Yeah.
I'm wondering, is the approach to radiation any different if the patient is or is not on chemotherapy?
Not really, actually. I mean, like in other words, like there is a concept of oligoprogression, like the few sites, even in patients who are on a chemo holiday. And the goal there, instead of staying the course with a given drug, is actually staying the course with no drug. And the decision making is often quite the same. If there's 10 spots that show up, then that's a sign that probably it's time to perhaps do radiation to one or several spots, but also reinitiate drug therapy. Does that make sense?
Yeah, that makes sense. A follow-up, so for example, with EGFR, like with the drug Tagrisso,
Yeah.
which I'm sure you're familiar with, sometimes you'll supplement Tagrisso with radiation, and you base that decision on just the volume of the cancer, the location, all those factors?
Yeah, I mean, the number of sites of progression, I mean, these days we've gotten really, really quite skilled at delivering the stereotactic body radiation, the high dose, highly targeted radiation. And that's actually what we consider an ablative dose, meaning if you were to biopsy that site, you shouldn't find any cancer left. So we've sort of knocked out that clone. And so, it would let you a patient stay on Tagrisso. And I completely agree, like the longer you can stay on a given drug, the more options become available. I can't count the number of times where a patient, is on Tarceva, and then right as Tarceva is failing, then Tagrisso comes out, and then who knows what's next, yeah.
Yeah, and I think, no, go ahead.
Oh, I'm gonna monopolize.
No,
but
no,
I do have
please.
a couple more questions. Okay. If the cancer is causing some problems in other organs, does that make radiation less viable, or would you be able to move forward with radiation?
Yeah, I mean, it really depends on the situation. So there is the concept of palliative radiation. So if the cause of that problem is like a local effect caused by a specific tumor, absolutely. I mean, that's a very, I wouldn't even consider that a highly modern use of radiation, where we could use the radiation, sometimes using the stereotactic technique to take care of that and thus alleviate whatever the problem was with that organ. But it's really case by case, and sometimes it's brought back to the multidisciplinary team in the context of tumor board to really decide, is this a more radiation, or more of a surgical, or maybe more time to invoke drug therapies.
Yeah, and I think we're going to jump into some sort of, into the late stage sort of arena with this. And certainly we've touched on lung cancer spreading to the brain. Lung cancer likes the brain. You've also heard me say that a lot, particularly small cell lung cancer. But it also likes other parts. It likes the bones, right? For example. Go ahead, Rick. And then I have a question online. Yeah.
Okay, quick question. So if you have a new patient that was recently diagnosed and they're ALK positive, and they just started alectinib, say, a week ago, all right, and they're already feeling better and coughing less, but they have 2 brain mets, and the original doctor was saying they might want to do stereotactic radiation on the brain mets because they're there. Would you wait a while and let the drug take effect first before going into the radiation? Because it does have risks. I mean, would you just, when do you think you should come into that situation with that type of a diagnosis?
It's an evolving area. So, I mean, there's all these targeted therapies now, from Tagrisso to alectinib, I mean, depending on the specific driver mutation, that actually do penetrate the blood-brain barrier. This was a real limitation across all of cancer, was that traditionally drug therapies didn't get into the brain very well, and we were completely dependent on surgery and radiation to treat brain metastases. I mean, it really depends on the context, because we actually could trust that alectinib is probably going to have some efficacy in the brain. And so it could be a fair approach to, if the patient's comfortable with this, give the alectinib maybe 3 months and repeat an MRI of the brain, see if there's response. If there's no response, jump in with a stereotactic radiosurgery at that time. I think where this has been most powerful, though, is in avoiding whole brain radiation. So you're probably not going to find a more enthusiast towards stereotactic radiosurgery in the brain. Like, to me, there really is no upper limit to the number of lesions to treat in the brain. And in the era of alectinib, Tagrisso, these excellent targeted therapies, I would actually favor using those instead of whole brain radiation, and then sort of pick off the non-responders or the suboptimal responders with stereotactic radiosurgery. So I would see alectinib as another important piece of the toolkit in that context.
Michelle?
I have a question online that is, what is proton radiation used for versus SBRT?
Yeah, so proton radiation therapy, it's an interesting type of radiation. There's really actually no proton centers in the Bay Area. And I mean, that kind of says something. But it's a charged particle, and charged particles interact with matter in a really different way than high-energy X-rays. And it has to do with how charged particles like sort of exit the body, and actually they actually don't exit the body. They sort of go in and sort of poop out, like at the area of the at the lung. You give up some of the features around image guidance and motion management with protons. So it's not like one is better, but it's just another way of having highly targeted radiation. And we, like most places, favor the stereotactic approach using photon radiation. Yeah, and using a standard linear accelerator. And why not just have one of everything? Proton machines tend to be extremely costly, and also in many cases require what's called a cyclotron that takes about a city block. So if you're in Manhattan, you're in San Francisco, it's going to be a little bit hard to find that space. So for now, I think that patients are extremely well served without it. But if there is a proton center in any given geography, there's nothing wrong with that either. Pros and cons. Yeah.
I have a question.
Yeah.
So you mentioned briefly or in passing side effects. Maybe you could talk a little bit more about that. Maybe you're going to get to that.
We are.
Okay.
Yeah.
Then another thing is, again, this is just my ignorance around this type of medical thing, but when someone's having radiation, is a person able to sit right there with them and hold their hand or anything?
Okay, yeah. So no. Like while the radiation beam is on, but only while the radiation beam is on, there is radiation in the room. Now, it's actually incorrect that the room is actually glowing with radiation. But in general, like, I'm actually the radiation safety officer among some other titles. Like, we really do need to be very judicious in exposure to radiation. And so the patient, a loved one can walk into the room with the patient, be there until sort of the last moment, but then when the actual treatment's being delivered, we have video and audio surveillance, and this would be really the practice across any radiation center, where the loved one could be watching and even talking to the patient, but from the treatment console, where the staff is there, and the staff, like myself, we all have to wear radiation badges to monitor. But the great thing is that behind the shielding required by the in the vault where the linear accelerator is delivering the radiation, really there's negligible amounts of radiation, so that loved one can be there close by if that's important. Yeah.
So different than really if you think about it, like going to the dentist and getting x-rays of your teeth done. They put that big lead coat on you, right? And everybody exits the room before they push the button. I mean, it's all about just creating safe environments and, for everyone involved. Yeah, and we are going to get to side effects, I promise.
Yeah. And also to be clear, like the patient is not radioactive the second that the radiation beam turns off. So there's no like recovery or convalescence period. It's for the most part, even with these complex stereotactic procedures, it's come and go treatment. Yeah.
Along the lines of the treatment, is it something that is ongoing for a number of weeks, or is it something that takes place once, or how?
Yeah, so it really depends on the context. So stereotactic, whether stereotactic radiosurgery in the brain or stereotactic body radiation therapy elsewhere in the body, that's going to be delivered over the course of 1 to 5 sessions. And then sometimes, when we're treating either larger areas or tumors that are up against critical normal structures, we're going to be doing what's called fractionated radiation. In that situation, we're really taking advantage of the fact that the damage caused by the radiation, cancer can't repair that, whereas normal tissues can. But we don't want to damage the normal tissues, so we're breaking up that big total dose of radiation that we know we need to treat and cure cancer into tiny doses that the normal tissues can recover from. And those courses can span 5, 6, 7 weeks.
Yeah. And as we walk through some of the stages and how radiation is typically done within each of these stages, we're going to have on here what are the typical, like how long are the treatments typically in that section. Anybody else before we jump into stages? Okay. Oh, Pat.
How long do you wait after finishing radiation and chemo and immunotherapy, and there's no progression? You just have the same spots in the same places. How long can you say? People say, "Are you in remission?" "No, I'm stagnant." That's all I can say.
Yeah. So I think I understand the question. When you're not undergoing treatment, okay, so you're done with treatment. When cancer doctors talk to each other, we use the word NED, no evidence of disease. And if there's like tumor spots, and this comes up all the time in the brain, so after we zap brain metastases, the brain doesn't have much of a sewage system, so usually you end up seeing sometimes it's a little bit of necrotic tissue, sometimes it looks just like scar tissue. If off therapy, that's not growing, that's not cancer. I mean, cancer grows if you're off therapy. And if you're NED for 5 years, that's a very good thing. Now, if the cancer spread from its original site, we wouldn't really use the word cure. We'd probably just continue saying NED. But if it's a stage 1, 2, or 3 cancer that has made it to 5 years without any sign of recurrence, that's actually when we'd all use the word cure. Doesn't mean there's no need for surveillance.
Okay, but NED means no evidence of disease, and they're still there.
Right. So if it's not growing, and then you can use other tools. At sort of one extreme, you could use a biopsy to see if there's any viable cancer in there. But sort of as an intermediate step, PET scanning can be quite helpful as sort of a non-invasive way of looking. Is this sort of active, or is this looking more like scar tissue? And I think it's really useful to talk to the radiation oncologist about their interpretation of it, because oftentimes we're the ones sort of untangling and unpacking what's in the radiology report. Like, wait a minute, it's still there. Is that cancer? Is that active? And if it's been 4 years since any therapy of any kind has touched the body, like, that's unlikely to be active cancer. That's a long time to wait. Yeah, it is a judgment call, and sometimes there is some subjectivity to it. Yeah, and some style.
But I think it's important to note what you're saying is that radiation therapy can leave something that looks like it might still be active cancer, but is actually either necrotic, dead, or scar tissue, right? But it can look the same. So that's where there's sort of that, you have to watch and see, is it growing? Because if it's growing, right, and you're doing a PET and they're measuring the metabolic activity, what does that look like? Although scars and inflammation can also cause metabolic activity, so it gets a little tricky. Yeah.
But the radiation oncologist should be able to weigh in on that. And if over time things aren't changing, that's a mighty good sign.
There you go, Pat. Bye, Sally. Happy birthday. We called you out again. I love your flats. Okay, I'm trying to be really mindful of time. Stage 1. What are some of the exciting things that have happened for folks who were diagnosed with stage 1, particularly those who, for one reason or another, might not qualify for surgery?
Yeah. So as of 2024, people with stage 1 lung cancer, if surgery is possible, that should be a strong consideration. But again, this is a local stage. This is a tumor in the lung of a small to medium size. And actually, stereotactic body radiation therapy, not to be harping on the same thing so much, that's a very exciting, very safe, very effective technology that in time might actually even displace surgical resection. So again, this involves using all the advanced tools that I described earlier, often fiducial markers, which help us track the tumor, all the imaging, the 4-dimensional CT, but giving somewhere between 1 and 5 sessions, typically 3 to 5 sessions, focused just on the tumor itself. These are tumors that have not spread to the lymph nodes, and we treat it. Very well tolerated, 90-95% local control rate. What about the lymph nodes? Turns out that well-staged patients with PET-CT and sometimes other ways of looking, like what's called EBUS, lymph node failure is less than 10%. So this would be considered curative treatment. It does have these sort of blast zones that you have to know how to kind of interpret in the area of the tumor. Sort of referring back to the last question, but this is a very exciting area. That's a real win for cancer medicine. It's a real win for patients with lung cancer.
Yeah, I couldn't agree more, especially for those folks who, like I said, for various reasons, people might not be able to withstand a surgical procedure. And so this is something that provides an excellent option with amazing outcomes. We keep talking about sessions, 3 to 5 sessions. How long is a session? I don't think we touched on that.
Sure. So like each session would typically, like the beam on time is usually about 10 to 20 minutes. What could vary is how long it takes to get in the right position. What also could vary is if we're going to be able to treat the patient continuously or actually target the radiation to the tumor only during specific phases of radiation. But typically, some of my patients might laugh because I'm often running late. But like usually like door to door is about an hour. Yeah.
Yeah. Okay.
Yeah. Give or take the Schiffner factor. Yeah.
There's a lot of laughing in the room.
Yeah.
I want to jump now to stage 3. And again, when I think about this from my own personal experience, those of you who have known me for a long time also know my mother, Bonnie Adario, and she was diagnosed at 3B. And I'm not going to get into all of the details around it, but after originally being told there was nothing they can do, she had, and there was pre-targets, right? Like Tarceva was still in trials at the time. Chemoradiation up front, lobectomy, repairs to the aorta, subclavian arteries, and then interoperative radiation, like post-surgery, and she's 21 years cancer-free since then. But I think that, especially for 2003, was a very unique sort of set of the treatment plan was very unique. It's not that unique anymore, and I think it's done quite a bit. So stage 3 covers, she was the B, there's also the A, and I think there's even a C now, I don't know. Let's talk a little bit about how we treat these patients.
Yeah, so stage 3 in general, so these are either very large or tumors that are abutting or involving things like the aorta, or tumors that have mediastinal lymph nodes, sort of lymph nodes in the center of the chest. And though I'm so happy to hear that your mom was able to get this very involved surgical approach and did so well with it, in general, like those are actually considered inoperable. And the benefit for surgery is more case by case.
Yeah.
And
Sure,
your
sure,
mom
sure.
had a great case.
Yeah.
In general, these have been treated with chemoradiation. This is again the multidisciplinary approach. This is a combination of radiation therapy. Since we're treating tumor and lymph nodes, this would not be appropriate for a short course like stereotactic body radiation, which is ablative. We can't ablate the center of the chest with the spinal cord, heart, esophagus. We need to break up the tumor dose into many small doses. It's typically 6 to 7 weeks of daily radiation, and we incorporate chemotherapy. The chemotherapy serves a couple purposes. One, it's systemic. These are tumors that may have the chance to spread. But the real benefit of chemotherapy in the context of stage 3 is actually that it's radiosensitizing. In other words, it makes the cancer cells more sensitive to radiation. And usually the medical oncologist and the radiation oncologist are collaborating closely. Drugs that you may have heard in the context would be carboplatin and Taxol, cisplatin etoposide, plus radiation. And that's how this has been treated for about 20 years. Turning the page to sort of 21st century really advanced oncology is the incorporation of immuno-oncology into this treatment. So there's a trial called the Pacific trial that compared patients being treated in the exact way described, what we call platinum doublet plus 60 gray of radiation over 6 weeks alone. And historically that's been associated with a 5-year overall survival, about like 25 to 35%. So good, but room for improvement. Versus that same program followed by 12 months of immunotherapy, in this case, durvalumab, okay? And the results are very impressive. So the 5-year overall survival was improved by 10%. So it went from about a 33% overall survival at 5 years with just chemoradiation to a 43% 5-year overall survival. Mm-hmm. So that's exciting. That's incorporating sort of the latest of cancer medicine, immuno-oncology, with what's been the backbone for many years, traditional chemotherapy and radiation. There's some interesting interplays between radiation and its ability to cause rapid cell death and therefore expose the immune system to the proteins, what we call the tumor antigens. And maybe there's some interesting synergistic effects that go in both directions of the immunotherapy making the radiation work better, and by exposing the immune system to these tumor antigens and the immunotherapy sort of ramping up the immune system, that there's some interesting interplays there as well, which is why we see that, a 10% overall survival benefit in the world of oncology is huge.
Yeah.
Yeah.
No, I think it's great. Is it the same? So we talked about chemo and we talked about IO, immunotherapy. Does it work similarly with targeted therapy?
So there wouldn't be that same like immunologic synergy. It's been known for a long time that radiation actually ramps up the immune system and can create these interesting immune effects. It's called the abscopal effect, where like usually when we treat radiation, we consider just a local therapy. But sometimes, it's hard to predict when it happens, it triggers a more broad immune response. And that's a lot more likely when you're incorporating immunotherapy. Sure. Yeah, and targeted therapy just wouldn't really have that, yeah.
Okay, that makes sense. Now I want to jump into stage 4, again with the combination therapies and some other, but before we jump into it, is everybody good? Michelle, we're good online? Okay. So let's talk about radiation therapy and stage 4. And I want to preface this by saying a lot of times I'll talk to folks, and this is maybe not even I'll talk to folks who are like, well, why can't they just radiate? I got that big fat primary tumor. Why don't they just get rid of that and maybe all the other ones will follow with the systemic, right? There's this sort of like logic concept that happens to it. Yeah. So why is that not effective, and why do you tell people no? Yeah. And what is effective, and what are we doing in stage 4 right now?
I so wish it worked that way. There was like the primary tumor was like the mothership, and then you sort of took out the mothership, and there's some, rogue, troops that after a matter of time they're going to wither away without the support. But with cancer, like it really only takes one cell to be its independent clone and grow a new tumor and then propagate cells elsewhere. So radiation alone, once cancer spread from its original site to another site of the body, what we call metastatic disease or stage 4 disease, really isn't the right tool. We need a systemic therapy like chemotherapy, immuno-oncology, targeted therapies to really wash the body over and treat all the sites simultaneously, as well as the microscopic sites that haven't shown up on a scan yet and therefore sort of prevent new spots from showing up. It doesn't mean there's no role for radiation therapy. If you want to walk through some of those, we can go through it. Yeah. Okay, so like, again, lung cancer, you correctly state, often does go to the brain. Again, the track record of traditional drug therapies entering the brain has not been as reliable as it is today. Now there's some great options, Tagrisso, alectinib, entrectinib. I mean, like, depending on your driver mutation, you're likely to find one. But in general, if the tumor is growing, we're going to either surgically resect it, but more typically use what's called stereotactic radiosurgery, where we're delivering really high doses. And what helps is that actually, if a cancer goes into the brain, it doesn't actually infiltrate the brain. It tends to generally like push the normal brain out of the way. So we can just target the tumor, avoid the normal brain, and as the tumor melts away, the normal brain sort of reoccupies that space. And that could be done these days in many cases just one session to treat. I mean, I think our institutional record is like more than 20 metastases in one session. And if more needed, more needed. So that's in the brain. Now, elsewhere in the body, again, we talked about the oligo progression scenario where a patient's on systemic therapy or not on systemic therapy, and 1, 3, 5 tumors start growing. We can stay the course with that systemic therapy and just pick off those biologically bad actors with stereotactic body radiation. And then there's also sort of the what we call oligometastasis, where they're even at diagnosis, there's just a few spots, 1 to 3, 1 to 5 spots. There's actually a clinical trial done called the Saber-Comet trial that included types of cancer other than non-small cell lung cancer, but many of the patients were non-small cell lung cancer. And what this trial did was it took patients and they had the medical oncologist give whatever the best standard of care, state-of-the-art systemic therapies, be it targeted, be it immunotherapy, be it chemotherapy, to treat the system. And according to the old paradigm, that's all that should have been done, and that radiation shouldn't have really made much of a difference, because the reason why chemotherapy or systemic therapies make patients live longer is it prevents new spots from showing up. So they randomized one group to get best systemic therapy to the judgment of the medical oncologist, and the other group to get same principle, the best systemic therapy, plus use stereotactic body radiation to treat up to 5 spots. And you'd think that maybe, okay, you'd control those 5 spots, but what difference would it really make to survival? And actually the 5-year overall survival in the patients who got the radiation was 43% versus like 13% in the patients who just got the drug therapy. So actually, by being aggressive locally in oligometastatic disease with non-small cell lung cancer and a few other types, not all types of cancer, you really make patients live longer. So it's not just perpetuating the ability to give the drugs. It's not just controlling spots and making scans look better. It's a dramatic improvement. And this type of trial has been replicated in other ways, but the Saber-Comet trial is really the one to know at the tip of the tongue.
Yeah, and I think it's things like that make me so excited about the future of cancer treatment and the role that radiation therapy plays. And also, again, to all of you in the room who know, I see you there, how we talk about clinical trials all the time. I wasn't going to say my promotion of clinical trials because I don't promote clinical trials, but I do definitely want you to talk to your healthcare providers about when and why a clinical trial might be right for you. And this is a perfect example. There.
No, I just have a statement. I think it's really important to realize, I mean, Larry had, I'm talking to the mic.
I'm just kidding.
Okay, now I'm talking to the mic. I think it's really important to understand that when you add stereotactic radiation, it improves your quality of life so much. And, I mean, we've had, 11, almost 12 years with metastases in all sorts of places that have been radiated. But I think, people get scared thinking of that as a last resort, but it's not. I mean, it's just this wonderful tool that makes things better.
I
Well
love
said.
that. Yeah. I love that, Thayer. And I think one of the things we're going to talk about in some instances is this sort of palliative approach. So sometimes cancer can get into places that cause great pain or. Can we talk a little bit about how it's used in a, well, maybe first explain palliative and then.
Yeah, so now we're transitioning away from like the curative or oligometastatic situation. Though, to your point there, the stereotactic body radiation can be used to palliate pain as well. But let's just say that this is a situation where we're using radiation really just to control symptoms. I mean, that's what we call palliative. Palliative is not the same as hospice. Palliative is not the same as comfort care. Palliative is really addressing symptoms. So we're not doing this to make patients live longer. We're not doing this for the oligo progression situation. We're doing this because a tumor is causing a symptom, usually because it's compressing into something, and we're going to use focused radiation to sort of relieve that compression. So common sites for this would be tumor growing in the bone. Bone is not cement. The outer layer of the bone is made of what's called periosteum, which is really richly innervated. And a tumor that's growing into that can be quite painful. We can use radiation to alleviate that pain. It works beautifully. Tumors hemorrhage. So tumors in the context of lung cancer that are in the bronchus, they can be causing bleeding and coughing up blood. Radiation works beautifully to end that hemorrhage. Tumors that are knuckling to neurologic structures like the spinal cord, we can use radiation to alleviate that pressure, and that can turn near paralysis into full function. Tumors that are knuckling into blood vessels, and in the context of lung cancer, there's a blood vessel called the superior vena cava, which drains the blood from the head. This is a scenario where we can use radiation to sort of keep that patent and open so that the blood flows back to the heart without obstruction. These are just some examples of how we use radiation for palliation. Really, this applies across the field of medicine to almost any tumor type.
Scanning the room, scanning the room. Yeah.
In terms of like the local.
There's a mic. Sorry, we just need to grab a mic, yeah.
In terms of like the local healthcare companies and organizations that, for example, like UCSF, Stanford, I forgot the name of your.
So it's called Palo Alto Medical Foundation. It's part of Sutter Health.
Are they all pretty much on the same page in terms of treatment, in terms of let's say let's say there's a stage 4 situation, and you're deciding how to radiate, etc. And so basically my question was, in terms of choices and decisions on their part, is it going to be pretty comparable? Because you get a second opinion, but on the other hand, if these high-level places are pretty much on the same page, I'm just wondering your opinion.
Yeah, so I think that there's a couple pieces to it. So one is like the technology, and there's a number of different vendors. I tend to be very vendor agnostic, but do believe that modern, advanced, safe, effective radiation therapy really depends on an institution that's dedicated to reinvesting and having the state-of-the-art technology. So that's a piece of it. So knowing that is important, but also like really the doctor matters. So like when you meet a surgeon, you're not typically asking like the brand of scalpel that they use. You're trusting the surgeon and their judgment and the skill. And what makes a good surgeon really isn't steady hands. I mean, yes, you need to have that, but it's good judgment. And the same goes for radiation. So meeting a radiation oncologist who lays out a sensible plan, who talks through the reasons for doing it, who's collaborating with a multidisciplinary team. There's a number of centers really across the country and across the world where you can find that. And find the best technology, but actually I think that it's the judgment that in many ways is more important, all other things being equal.
Anybody else? No?
I'm really tempted to ask this. I've been scratching my head about it. My doctor, I trust her completely, my radiologist, and she recommended the treatment phase that we're in now is to do 3 to 4 radiation treatments to work the mass out. And of course, I was excited. But then we got a reply from the insurance company, and they said, well, we believe through our expertise that you need 6. And so that kind of didn't make any sense to me that they would increase the treatments versus my radiologist that I completely trust. And I just thought it was, I couldn't get over that part. And those extra 2-3 treatments weren't fun. I would prefer not having them. So maybe this is for...
Yeah, it's hard to sort of speak for the insurance companies with sort of a sympathetic, like, sort of explanation.
I don't
but I mean, part of modern medicine is dealing with payers, and I mean, I can't even imagine what that situation is. So yeah, but it does bounce back to the treating physician. So if an insurance company were to say to do something that you vehemently disagree with, it's absolutely appropriate and necessary for the treating physician to appeal the insurance company. And I've never lost an appeal. Like, it's never happened. It's never happened once. Even if I was to go to the state, like, if you can articulate your case and you can cite evidence, it will go through. So presumably if you ended up on the 6 treatment course, your treating doctor felt that was an acceptable alternative.
And it's so interesting when you think about payers, and that's a whole living room all by itself, right? Just to give a quick example, and if Sally was still here, I think she was actually at that meeting. Tina, you might have been too. Larry, I don't know if you're here yet. Anyway, we had a woman, she's since moved out of the area, she's still doing very well, but she had fiducial markers placed for radiation therapy, which her insurance covered, but then they didn't cover the therapy. So they covered the marker placement, but they didn't want her. And when I tell you she lost her mind, and my whole point about saying this is because patients can advocate with their insurance providers as well, right? They can be part of that conversation. Because she got, I won't name the insurance company, but she got all the way up to the CEO and was like, this is not happening, right? And obviously they wound up covering it. But sometimes those things happen. Yeah.
Good point. Put in a plug. So, like, who's the customer of the insurance company? It's the patient.
Yep.
The physician is the expert, the consultant, and that's why they tend to listen to us, especially in radiation oncology. It's sort of an esoteric field. But yeah, it really does matter to get on the phone with the medical directors of the insurance company and make your case. And I don't think it has to be made with raised voices. That's certainly not my approach. Yeah.
I do. We're already, well, we started about 5 minutes late, so we're really only 5 minutes over right now. But I do want to cover side effects, if that's okay. Talk a little bit about what people can expect during and post therapy.
Yeah. So, I mean, radiation does have side effects. You know, I think anyone who's gone through radiation has had at least some side effects. And it really has to do with where we treat. So side effects in the lung versus the brain are different, but just to focus on the thorax and the lung. You know, anyone going through a course of radiation will usually have some degree of fatigue. The fatigue with radiation is not quite like chemo. It's not like getting sick with radiation. It tends to be more of like a late in the day, you know, feeling more tired, like almost like if you had a big day. That's something you can really expect, and that would go away after the treatment's done. When we're treating in the lung, your radiation oncologist actually should be able to predict, not at the first handshake, but before they start the treatment, what the likelihood of radiation causing damage to the lung that would be noticeable with shortness of breath or cough. That's called radiation pneumonitis. Or once that process sort of burns itself out, scar tissue in the lung called fibrosis. And especially like symptomatic, like to the point that a patient would notice a change in their breathing. And usually that should be very low risk. And if the radiation oncologist were to be asked, and that's a very fair question to ask, usually we'd like to keep that less than 5%. If the tumor is close to the esophagus, because that esophagus runs through the center of the chest, then there could be a risk of like sort of a heartburn sensation, what we call esophagitis. That's really common when we're treating the lymph nodes, because the lymph nodes are right around the esophagus. And then, if the tumors are close to the chest wall, there could be risk of damage to the chest wall, or even in some cases, rib fracture. And I mean, I don't think you have to go too far to have met some people who've had some of these side effects. They're real. Sometimes they're very rare, like the rib fracture is really rare, but if you see enough patients, you'll see it. And the advice to the radiation oncologists out there is listen to your patients. If they're telling you something, listen to them. It's how you learn. It's how you identify the 1 in 1,000 toxicities. But those are sort of the big ones to touch on.
Yeah, and I think the esophagus, the food tube, right? So is a big one because sometimes it can cause you not only some of the vocal cords and laryngitis and things like that, but trouble swallowing and eating and drinking and that type of thing. And again, this is where palliative or supportive care can come into play, and having these conversations with your healthcare provider about these side effects in real time to get ahead of it so you're not behind it is so incredibly important, because there are tools and tricks out there to help support through some of these side effects. Rick, I see you.
So a quick question. How can they make it for the brain, CyberKnife, how can they make it more predictable? I had CyberKnife 3 times. I had it in 2017, I had it in 20, and I had it in 21. First time, piece of cake, walk in, walk out, everything's great. You're tired for 2 days, who cares? The second time, I got this really bad radiation necrosis, which can actually be life-threatening. It got pretty bad. So something that was the size of, half an inch or whatever, a centimeter and a half, became this necrosis that was, 5 centimeters. It was huge. Anyway, a year later, I needed CyberKnife again on 2 other spots. And I'm like, are you kidding me? You almost killed me last time, right? They said, no, we think with the Avastin and with the steroids and stuff, you'll probably be fine. And I had it and it was fine. So how do they make it more predictable for what you're going to get? It's like a box of chocolates. You never know what you get.
Yeah. I mean, when we give stereotactic radiosurgery to the brain, radiation necrosis is possible. I mean, there's just no way around it. In the best of hands, it can and does happen, and it's obviously a step we like to skip, but sometimes it does happen. And so, like the way as a radiation oncologist we use our judgment. So tumor size matters, and then again fractionation. So instead of giving it all in one treatment, breaking it up into like 3 to 5 treatments. One of our practices is we give a drug called dexamethasone, which is a potent steroid, after each session to try to prevent, the radiation edema or swelling or necrosis. But again, even in the best of circumstances, it's unlikely your doctor could have done anything differently, and it just sort of happens. Yeah.
Charlotte's joining the party.
Yeah, good.
Are there any more? Yeah.
Okay, in the multidisciplinary approach, one of those approaches would be, eating organics and having vitamins and minerals and so on. When you get radiation, are there any of those types of things you have to avoid, or does that not figure into the equation at all?
Yeah, no, that's a great question. I mean, actually, one of my areas of great interest is sort of like lifestyle medicine, like what can we do in sort of the wellness realm to make our cancer treatment go better. I will say that there's very few like real concrete guidelines. So as far as like diet, I actually advocate for a plant-forward diet, like not necessarily vegan, but really having like 5 to 8 servings of fruits and vegetables a day. And like a serving is about the size of your fist. So like an entree salad isn't 1 serving, that could be 5 servings, depending on the size. And then a good source of protein, again, doesn't have to be vegan, but I mean, there are good plant sources of protein and beyond. As far as like things not to do during radiation, really during cancer treatment in general, I think weight loss needs to be avoided. Like across all cancer types, like a weight loss of more than 10 to 20% of the initial body weight is a negative prognostic factor. So people who go too extreme with things like juicing or something like that, I mean, juice is great, fine, go for it. But really who are eliminating so much that weight loss is alarming, that's typically counterproductive. And then as far as like specific things during radiation, there's a theoretical interaction between high-dose vitamin A, C, and E in radiation that's actually not helpful. So we usually advise patients to hold off on like high-dose vitamin A, C, or E, like the kind you'd see like if you got like 1,000 milligrams of vitamin C, like that's a normal supplement you'd find at Safeway or any pharmacy. That has like 1,500% of the daily recommended allowance. Like you don't need that. Rather get those antioxidants through those 5 to 8 servings of fruits and vegetables, and you'll be good. Yeah.
Okay, and quick follow-up question to that. If one is losing too much weight, what do you recommend to put on weight?
Yeah, I mean, like, so we would involve, part of the multidisciplinary program is the, cancer dietitian. So we would involve that individual very early in really counseling on goal target as far as calories go. But I think that the key thing is that presumably the reason for that weight loss is that despite best effort, like you're just not getting enough calories. So everything that has to cross your lips has to be very calorically dense. I'm a big fan of smoothies. I think that a smoothie like with a basis of like whole milk, and it could be milk of your choice. It could be soy milk, or it could be almond milk, your choice. A protein source. It could be nut butter, it could be yogurt, it could be ice cream, and then supplement it with the fruits and vegetables that's to your liking, and be sure to drink it is excellent. There's some really high, so some people obsess about their ingredients, but they don't drink it, so not as helpful. And then there's some supplements that are made by a variety of manufacturers that are sort of highly calorically dense in a small volume. And there's one made by Nestle called Benecalorie that's 330 calories in 1.5 ounces. It looks like that's about like what a shot of alcohol is with 330 calories. If your goal calories is 2,000, it doesn't take much of that to get you where you need to be. Now, you shouldn't live on Benecalorie, it's gross, but like, if you blend it in with a smoothie, a couple of those a day, it can help a lot. And a cancer dietitian or a doctor who sort of knows how to counsel patients around this can be a great resource around that.
When you were talking about radiation side effects,
Yeah.
Radiation side effects, and you were talking about the lung, you were saying like how after radiation it can affect your breathing because there's scar tissue and stuff. Is that ever like restorable? Like once that happens, can the lung go back to what it was before or not really?
Sure. So two answers. So there's what's called radiation pneumonitis. And so that's something that your radiation oncologist should be able to predict. There's models for how we do that based on the treatment planning and some metrics on like the volume of lung radiated versus the total volume. And so the logic there is like if you're radiating the tumor and treating 2/3 of the lung, that's going to be really high risk. And that would prompt some real informed consent, okay? And then there's going to be times where you're treating a small area and the risk is going to be less than 1%, where we might not have to spend quite as much time talking about it, maybe more in passing. But radiation pneumonitis is just inflammation, like pneumonia, which is a inflammation caused by bacteria or virus. Radiation pneumonitis is inflammation caused by radiation. Usually that starts 6 weeks after radiation. So people are getting a cough during radiation. It's not radiation pneumonitis. It starts 6 weeks after radiation and sort of peters out by 6 months afterwards. And sometimes that can transition to radiation fibrosis, where there's like a volume of scar tissue. Radiation pneumonitis is self-limited. Sometimes we'll give a course of prednisone to really beat that down and get that back under control. But radiation fibrosis can be irreversible, which is why the judgment of the radiation oncologist is so crucial, regardless of the technology, regardless of the brand of linear accelerator, or the flashiness of the website. You really have to trust the judgment of your radiation oncologist. Yeah. And if they really start talking about high risk of pneumonitis, that's kind of what I'm talking about. Yeah. And if they say the risk is low, then that's based on sort of the metrics. Yeah.
So I want to close out tonight with Dr. Schiffner. What do you most hope people take away from this conversation tonight?
Yeah, so number one, if radiation is brought up in the context of your recommendations, it is very safe. It's very targeted these days. It's not getting nuked by any means. it can play a role across the full spectrum of lung cancer presentations, stages. And go with a team of doctors or a radiation oncologist who you trust based on the conversation you have with them, with the sort of openness and transparency of how they're making their decisions. I like to play the game open hand. The reason I'm making the decision should be very understandable to the patient, because it should make sense. And then from there, it'll all be taken care of. Yeah.
I love that. I cannot thank you enough for coming and for staying longer than I asked you to, or we asked you to answer some of these questions that I know are going to be helpful not only to the people watching tonight or here tonight, but those who are going to come back and watch it later. So thank you, thank you, thank you, thank you, thank you. I'm going to take the next 30 seconds to go through a couple of housekeeping things. I know Genevieve for one. Rick. Hi, sorry, I'm doing housekeeping. Yeah. The text to remind. So I know Genevieve said she wasn't on it, so I do want to remind everybody, if you're not on it and you would like to be, there's absolutely no pressure. But sometimes the third Tuesday of every month comes around real fast and we forget. So we've launched a text service last month to remind folks about this programming. And Rick says it works great. But if you'd like to receive these reminders, Genevieve, you're in the room, so we can give you the information. But it's going to come up on the screen for those of you who are watching. You just have to text the word living room, all one word, to 844-871-7558. That information is also available on our website on the Living Room page, so you can get that information there as well. You can actually stop it at any time if all of a sudden you're annoyed that we're reminding you. Just text stop, and it'll stop texting you. I want to remind everybody, Gathering Hope, October 8th. If you're not familiar with Gathering Hope, it's our community social hour, which has sort of taken over what used to be prior to this, which was an around the room where patients kind of shared their stories and talked through their experiences. We now do that virtually online with folks from all over the country. Michelle moderates along with our very own Larry Gershon, who helps moderate from a patient volunteer perspective. October 8th. Our next living room is Dr. Shane Dormady. So I know we haven't seen him in a long, long time. So he's at El Camino Hospital just down the road here, and he's going to be coming and talking with us about, he changed it up on us, which I will never stop giving him a hard time for, because we already sent everything to marketing. But anyway, it's going to be around evolving strategies for treating EGFR mutated non-small cell lung cancer. It's a hot topic right now. Folks have been doing really, really well that are EGFR positive on a lot of the TKIs that have come forward, but there's sort of this what's next sort of thing going on right now, particularly post Tagrisso. So he's going to come and talk a little bit about, or a lot of it about that. I want to say again, thank you to Dr. Schiffner for coming and talking. I know we've been, like I said at the beginning of this programming, poking you for a while to get here, and we could honestly
blame it on COVID.
We could, yeah, we could not be more grateful that you came and spoke tonight. All of you in the room, all of you watching live or post live, thank you, thank you. Penn Media for coming in here early afternoon, the third Tuesday of every month, and setting all of this stuff up for us. Onyx and Ash for, not Ash, Onyx and Ash. They'll edit that out. It's fine. For doing the edits for this to be hosted on our YouTube afterwards, and then of course Michelle Zay and the GO2 staff for all the support that they give to this programming. Very, very, very last thing is all of our supporters. I can usually get this done in one breath, but Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Daiici Sankyo, Eisai, Foundation Medicine, no I can't, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, Takeda, Oncology. Thank you, thank you, thank you for your ongoing support of this very important programming. And until next time, there's dessert. If you didn't get dinner, please come and eat. And thanks for coming, everybody.
So I'll be brave if you're brave. I'll be brave, but only if you're